Matthew Budoff and Mike Gibson coming to you live from AHA 2022, talking about something that I think is really critical. I really do think the GLP-1 agonists and semaglutide are really game changers. I mean, we have a diabetes epidemic, particularly in America, but around the world. And the idea that you can lose 35 pounds on this drug, I think it could really change the course of heart disease in our society, and I'm very excited about it. And people know I've said I took it, lost 35 pounds. So I'm very excited to see what you found, Matthew, with respect to reversing atherosclerosis.
Yeah, so we were very excited. The Sustain 6 trial and the Pioneer 6 trial were two outcome studies with semaglutide. They both showed event reduction, and MI, stroke, and CV death went down. So it sounded like it could be an atherosclerotic plaque regressor like statins and other therapies. What we found was actually more of a neutral effect on the overall plaque, but we found a very strong conversion of non-calcified plaque to calcified plaque, which is
Hmm.
exactly what statins do. And we believe by delipidating the plaque, you're going to actually end up with a more stable plaque. And that might be one of the mechanisms of benefit of this therapy.
Yeah, I mean, this happened to me. I have a calcium score of 1118, but it's all calcium. It's not any fat. So I think, this delipidation probably occurred. Now, is it good to I mean, it sounds kind of scary to have all that high calcium score, but I have a low CRP. Is it bad to have, these kind of fibrotic calcified plaques? I mean, if there's no luminal obstruction?
Yeah, I think, if there's very little lipid that, plaque rupture, the vulnerable plaque is this low attenuation or this necrotic core. And if it's delipidated and there's none of that, then I really do believe that these patients end up being very stable. So,
Mhm.
having a lot of calcium means at some point you had a lot of athero buildup, but if it's only calcified plaque now, and we can tell that we have automated plaque tools, we can see
Right.
what percentage of your plaque is calcified versus non-calcified. And I think that is one of the benefits that we were able to see in the STOP trial, albeit a little disappointed that we didn't see a more robust percent, regression of plaque compared to placebo. But we did see this nice conversion, which I think is going to be food for thought and possibly future studies.
So we have outcome studies, we have the imaging studies, but do you have combined studies looking to see if that imaging change translated into clinical outcomes?
So we have that with many other
Mhm.
other agents. We did the Evaporate trial with
Right,
Vascepa, and the Reduce It trial with that same agent was
right.
very positive. We have a testosterone study we published in JAMA that shows testosterone is bad for the coronaries. And in New England, there was a paper, the TOM trial, that showed that testosterone is bad for events. And there's a lot of other parallels with statins, with other agents. So I think that there is good tie-in. Colchicine has nice plaque regression data and,
Mm.
of course, has some positive outcomes. So I think there is a good tie-in between what happens in the coronaries and what happens in the outcome studies. But not every mechanism is purely atherosclerotic.
Now, a lot of people are having a hard time getting semaglutide. In fact, there's some manufacturing lagging behind the demand. I hope we can get it into the hands of more patients.
Yeah, I've been told, and I've had that same problem with my patients,
Hmm.
that is hopefully resolving before the end of the year. But there's as you said, a huge demand and a limited supply, so they're fighting for those milligrams of
Exactly.
semaglutide.
Exactly. Well, great study, Matthew. Thanks for joining us, and thanks to all of you for joining us here live from AHA 2022.